Good afternoon, everybody. My name's Sue Whelan and I'm the new chair of South Warwickshire and George Eliot Trusts. I'd like to give a very warm welcome to all members of the public, governors, volunteers and colleagues joining us for April's joint board. It's the first day of the financial year, so everybody's feeling like a new page has turned. And I just wanted to take a moment to give 3 sets of thanks. First of all, I'd like to thank Russell Hardy, the outgoing chair. Russell has been absolutely relentless in the time that he's given me to help my onboarding and to make sure that we continue to support these 2 brilliant organisations the best that we possibly can as a board. And also he's made a phenomenal impact over the last 10 years at SWFT and much wider across George Eliot, Wye Valley and Worcestershire Acute. So really indebted to Russell, who will remain a good friend of the Trust, and we're delighted to be able to work with him in his new role as Chair of the NHS for the Midlands region. Secondly, I'd like to welcome back Glenn Burley from his work at national level. We haven't quite been able to entice him fully back. He's going to be helping the national team on a reduced basis for a few months, but we're really pleased to have him back at the beginning of this financial year. And then finally, to thank Adam Carson for his sterling, determined and productive leadership during Glenn's absence. It's been a really busy time for the Trust, not only for healthcare, but also in bringing the joint leadership of the 2 trusts together. So we're really indebted to Adam and all he's achieved, and we're delighted that he's with us in his capacity as Managing Director of the 2 trusts. So, on to the formal business then. First of all, apologies for absence. We have apologies from Paul Capener, who's the George Eliot NED, and I believe we're quorate. Any new declarations of interest? No? Good. So the first and a really enjoyable part of the agenda is recognising our Going the Extra Mile GEM award winners. So we're looking at the Winter Awards for 25-26, and we have 2 to give out today. The first of those is the Individual Award, which goes to Bradley Turner. Bradley Turner, the nominator, said, I'll read out the nomination. During a routine transfer of a patient, the patient began fitting. Brad calmly and effectively turned the patient into the recovery position, applied a oxygen mask and called for help before returning the patient to the emergency department and taking them to resus. Without this quick thinking, the outcome for the patient could have been very different. Not many medical staff would have acted this quickly and effectively. On top of that, Bradley is an absolute asset to the A&E team, trustworthy, quick thinking and extremely hardworking. He was working alone during this transfer and demonstrated multiple trust values. He's safe, effective, compassionate and trusted. He's well loved and respected and consistently shows these values in his work. So Bradley's too busy to join us today, but we wish him all the very best and we hope that he continues to take just as much pride in his work. The second winner, who I think we have with us somewhere, some colleagues from Fairfax Ward. Fairfax Ward have been awarded the Winter 2025-26 Team Winner Award. The nominator said that despite the pressures, the team consistently maintains a high standard of care, ensuring that the patients remain prioritised daily. The team is truly a pleasure to work with. They actively support trust-wide improvement and fundraising, and they play a fundamental role in enhancing the overall patient experience. Sincere appreciation extends to the ward manager, Maya Garrett, whose compassionate leadership has fostered this supportive environment. Under her leadership, care processes such as safety huddles, bay handovers and stay-in-bay tagging has been implemented, which has improved patient safety, reduced falls and contributed to a reduction in length of stay. The achievements of this ward really reflect the Trust's core values, and they set a very high standard of leadership and teamwork which inspire other people. Have we got Fairfax here on the call with us? I'm sure we'd all like to give them a round of applause. Yes, I think so. Yes. There you are. Wonderful.
Yes. Thank you.
Thank you very much. Right. On to the minutes of the joint board held on February the 4th. Are there any comments or amendments to those minutes? Please raise a digital hand. I can't see any. Brilliant job on the minutes. Thank you very much. I'll sign those in due course. And we're on to matters arising. Hang on a second, let me just get there. So many of the matters arising have been completed in months, so they can all come off. I think the first one we're going to look at is minute number 262409. Ashi, this is regarding blue badge car parking. Do you have an update? Harkamal.
Thanks, that one's for me. So I do have an update. Kirsty Webb from George Elliott has looked into it and has contacted Mr. Hunt and has resolved this issue. And we will be clearer around making sure that patients and relatives know to go to reception, and we can help them out in terms of any blue badge queries moving forward.
Thank you. And the next one down here, 261406B, the managing director to meet with Robert White and Paul Capener around the best approach for the bath. Has that taken place?
So we haven't had that meeting yet, but we have progressed work on the bath and risk management approach actually over the last week or so. I will meet with Paul and Robert to finalise that over the coming weeks.
Thank you, Adam. That'd be great. Over the page then, 250724D, quite a mouthful, these references. Fiona, this is around improvements in the volunteer recruitment process.
Yeah, I have reached out to recruitment to ask them to review it, and I did get a response back to say that they would pick it up. I haven't, Sue, to be honest, chased that up in the last 6 weeks, but I will ask my my colleagues in recruitment to give us some feedback on that.
Thank you, Fiona. Let's keep that one on and we'll hear next time. From George Elliott Action, from the 2nd of December, we've got the Sustainability and Waste Manager to expand more on the 21 actions identified under the theme Suitable Models of Care and report potential learnings into the foundation group. Sophie, is that best covered when we talk about the green plan?
It isn't covered in the detail that was requested at that time. Sorry, I've just had a coughing fit. And I'm waiting an update from Sean on this. So if we can carry that forward, and I'll clarify at the next board. But I think it will go into the group when we have a shared board at group level, whereas the reporting to deck just has a higher level version of the plans.
Okay, great. So shall we transfer that one over to foundation group?
Because it's about the shared learning. So yeah, I think that would be helpful.
Let's do that. Okay, that sounds good. And then we have the Foundation Group Board Workshop report from the meeting held on the 4th of March, which we're receiving and noting. Glenn, would you like to take us through that?
I don't think Glenn's here, but I can cover that. So Sarah's got her hand up there.
Thank you. Sorry, could I just go back to the action log and provide an update against action 2507-04A, which is relating to patient forum reports to the board?
Yes,
Yeah.
please do, Sarah.
Thank you. Fiona and I have discussed it, and there's actually going to be inclusion of their an update from the patient forums included in the quarterly patient experience reports to the board. So it won't be separate agenda item going forwards for the board. So that I think that action can now be closed.
I agree, Sarah. Thank you.
Thank you.
Thank you, Adam. I should say that Glenn will be stepping in and out this afternoon, so Adam's kindly going to take this report for him.
Thank you. Yes, so I will take the majority of the report as read, but just to mention, this was our first Foundation Group Board's workshop in a new format. The Foundation Group Board, as Sophie just referred to, is a forum for shared learning and getting together and learning from each other. So the new workshop format is helpful in that approach. And this was in fact the first time we'd met as a Foundation Group Board in person since COVID. So the day was very productive. We had a number of sessions led by chief officers on that theme of sharing best practice across trusts. We also celebrated Russell's tenure as chair of the group, and it felt like a fitting end to his term with the celebrations. We also had some great talks in the afternoon from Christy Waring, the chair of the ICB, and Simon Trickett, the chief exec, and from David Nicholson, former chief exec of NHS England, about his experiences working in the NHS. So I think all of the members there got a lot out of the day, and certainly on that theme of sharing, it was very useful.
Thank you, Adam. And we've included here quite extensive detail in terms of the performance report from February for all of the trusts in the Foundation Group. We think it's perhaps a little too comprehensive, and next time we will look to streamline it and perhaps put it in an appendix. But it's really helpful for us to be able to contrast the performance of SWFT and George Eliot with that of the rest of the group and continue to share best practice at pace. So there's plenty here that others can learn from too. Okay, so moving on to Chair's remarks and review of key discussions from this morning. This morning, as usual, the board spent time working together on strategies and working in partnership across the ICB. We started the morning with a patient story. We were focusing on the improvement work underway to give better experiences to people who are suspected of, diagnosed with, or treated for cancer. And we were very pleased to welcome back a gentleman who has been helping us with this journey now for 4 years, and to hear about his reflections on how things are improving and what still needs to be done. We also looked at the future with Warwickshire-wide transformation to neighbourhood health. We were looking at the use of population health data to support prevention and better care closer to home, working with primary care, local authority colleagues, and the integrated care team from the ICB. This is really exciting and transformational work, and we will be bringing more through board throughout this year and beyond. We had a finance update, you won't be surprised to hear, because of it being year end, and we also looked in some depth at the plan for this new year, which is on the agenda shortly. And finally, we were joined by colleagues from the CQC to hear about their new processes for what's now called trust level assessment and previously was well led. So keeping up to speed with how care providers are regulated. So a very diverse and interesting morning. And the final point was that we looked in some depth at sickness management because we want to support our staff to stay well and be back in work as soon as possible. So that was this morning. Moving on to strategy, Adam, would you be able to take the Chief Executive's report?
Sure, I will take the majority of the report as read. There is more detail on a couple of particular items on here. So we've got the staff survey report coming later and the medium term coming later, as you say, Sue. Very positive on the staff survey, again above average, but I won't steal Ashley's thunder on that. The point I did particularly want to pick up that's in the report is the depressing update on the instances of violence and aggression we're seeing across our services. So I think particularly in the last few months, but this has been on the rise for the last few years, we are seeing increasing instances of violence against our staff by patients, their families, and members of the public. And while we understand sometimes wait times can be frustrating for members of the public, instances of violence and aggression are never acceptable. We have seen some particularly harrowing examples at George Eliot just in the last month of attacks on our staff. We have, of course, got the police involved in those, and we will always press charges against perpetrators of crime. But I do just want to reinforce to members of the public listening to the meeting today that our staff come to work every day to provide a service to care for patients, and they do not deserve to suffer attacks in the line of their jobs. So I am commending our security teams for the great work they do and commending our staff for the support they provide in challenging circumstances. But it is extremely depressing that we are continuing to see these incidences rise. Thanks, Sue. That's all I will pull out today.
Thank you, Adam, and thank you for making that important point. Comments and perspectives, questions from the team. Umar.
Thank you, Sue, and thank you, Adam. Adam, can I just ask, are any of these attacks either racially motivated, religiously motivated? Because with the current climate as it is, if they are, then I think there's something that possibly we need to focus on in terms of trying to bring about awareness. So if you could enlighten me, that would be much appreciated.
Yes, and you're absolutely right, Umar. There are a significant proportion of these incidents that are racially motivated. We've got the data actually about the number of instances and the number of that are racially motivated. So I'm happy to share that with board members. We have done a fair amount of work on awareness. We've obviously had the No Excuse for Abuse campaign across both organisations, which focuses on racial violence, but violence generally as well. And clearly, we continue to invest in equality and diversity initiatives. I've also raised this recently with our MPs, and they have escalated further to the Secretary of State. I think this is a picture we're seeing across the country. But I do think you're right that racially motivated instances are on the rise.
Thank you. If I could just come back on that, Sue, Chair, if that's okay. I think it's really sad to hear that is the case. You know, we're in 2026 and we're now talking about, you know, those types of incidents. So it's really good that you've got the data. I think that the zero tolerance approach obviously is something that the NHS in general and the trust focuses on. But I think it'd be really good to see that data because we need to try and tackle it head on now. before it gets wider and wider. And you know, it's really important, not just for our staff, but also for our patients and our communities who want to feel safe coming in to get medical care.
Thank you, Umar. Yes, let's take a look at the themes and demographics. And of course, we have our anti-abuse campaign running currently. Fiona.
Yeah, I just wanted to add to the conversation, really. We recently, a couple of weeks ago, did a night visit at George Eliot, which many of the NEDs accompanied us on, and that was specifically about staff safety at night. We know a lot of our staff from a diverse cultural backgrounds work at night, and so added to lone working and security at night, so it was important to have that conversation. My impression was staff on the wards felt safe, but the racism and racial abuse from the public was predominantly felt in A&E. So I think, I don't know if others had other comments, but I was reassured that staff, this was at George Eliot specifically, generally felt that we were doing the right thing to protect them. But we do need to strengthen at the front door, I think, the members of the public as well as patients.
Thank you, Fiona. Thank you, Adam. There's no other questions. We'll move on to the annual objectives for both trusts. These have been developed with governors, with leaders, with partners, and crucially, ground up through colleagues. So I know that they've been seen before by members of the board, but formally, are there any other comments or questions at the moment? Great. We will, members of the public may well be aware that these themes are now well embedded across the two trusts and are very much in line with the NHS 10-year plan. So, talking of planning, medium-term plan, including the financial, operational, workforce and capital elements. Can I take this opportunity to welcome Ravi to the board as the Chief Finance Officer? We're delighted to have her on board.
Thanks, Chair. I'm just going to take the paper as read. The paper details SWFT's and George Eliot's 3-year financial plan and 4-year capital plan. It sets out the annual plan for 26-27, risks and mitigations, which we've been through a number of times as a board. And as you said, Sue, in your introduction most recently this morning, the final plans have been submitted as part of the national process on the 17th of March, which we did under delegated authority.
Questions and perspectives on the medium-term plan? I had one. Ravi, we've got the EPR coming in and there's a risk shown here around avoiding lost activity or accepting that there will be lost activity. I wondered, have we looked at the impact on activity in trusts that have put a Cerner system in and used this to help us to mitigate? And I appreciate that that work might still be underway, but if it's not been done, is it planned? Robin.
Yeah, thanks, Chair. We've done a piece of work working with NHS England and KPMG, looking at the last 17 rollouts across the country. Some of those are using the same system that we're looking at, which is Cerner, Oracle Cerner Millennium, and some are other systems. So we've looked at a broad range of EPR implementations. We've looked at the data from each of those. We've also then looked at our own activity data and looked at what learning we can take through our programme in order to minimise the productivity loss. I think the one thing that is key, what is clear from all of them, is that there absolutely is a productivity loss after an EPR go live, and we should expect that. But what's coming from the learning from others is that on average that lasts for about 4 weeks, with a learning curve back to 100% after 4 weeks. So we will be obviously looking to minimise that and taking mitigating actions.
Thank you, Robin. That's really clear. Ollie.
Yeah, thank you, Chair. So a really good plan. Thank you, Ravi. I thought it was very easy to follow. The CPIP targets, as you acknowledge in your risks, do look a bit high. My question is, will staff respond to the CPIP programme quicker in previous years? Sometimes it's taken quite some time to recognise where those savings are going to live.
Yeah, thanks, Ollie. I hope so. We are putting in a new programme of work at the moment, so be part of our day-to-day CPIP programme across the 2 trusts. We're putting in a transformation board, and then there will be the day-to-day CIP programmes that will sit within the divisions. As part of that and setting the CIP target, we have already identified as part of those 6 broad schemes the values that we potentially think we can realise for the CIPs. That's all been shared with the divisional directors. So yeah, we're ready to get started with that. And Sophie and her team are supporting that transformation programme. I think we've got a meeting at the end of the month.
Thank you, Ravi. Sophie, did you want to come in?
Mine's on a slightly different point, but just to follow up on that, yeah, I think it's still not going to be as fast as we would want it to be. I think we've got to aim for that for the following year, but it does feel like Ravi said that there's a reset and a step change then, and also that ability for us to work across Swift and George Eliot and like lift it up and have that like much more robust corporate response alongside the divisions to make the CPIP programme work. And we talked as well about the benefit of the different lenses, so getting back into that, like multiple lenses, not just finance. And so I think as an exec team we'll be setting that from the start, and hopefully that will galvanise a bit more traction as well. My point, Sue, if that's okay, was just to reference and pull out of Ravi's report around the capital. So it's just to note that whilst those are the capital allocations we have submitted our plan, the ICB have confirmed that they will be doing a process around the allocation of the constitutional standards funding. We have put a number of queries in around specific projects for George Eliot and Swift that weren't supported. And so that assurance has been given by the ICB that they will do a process and kind of with us now so that we can understand those allocations. So just to note that ongoing work.
Thank you, Sophie. And I'd also like to note and commend the team for the work done to get to a point where George Eliot will not be taking deficit support funding in its plan for next year. I think that this is a real testament to the work of colleagues over a number of years, and it's really an important and motivational, it's a removing of a cap essentially, and I think that that's a real testament to the leadership and colleagues throughout George Eliot. So thank you very much for that. So we need to approve that. If for any reason you're not willing to approve the medium-term plan, please raise a digital hand. No hands raised, so that's approved. Great, and almost you set yourself up perfectly, Sophie, for the capital programme update report. It says it's to approve, but it isn't to approve, is it? It's to note. Is that correct?
Correct. It's for information.
Thank you.
So we like having capital, which is why we're arguing for more share of the constitutional standards pots, because actually at George Eliot and Swift we do have poor estate, and we're really keen to make sure that we modernise that estate when we talk about the wellbeing of our staff and the care that our patients deliver. It's a really important component of that. Just to end, I guess, the capital programme that we've had. So at George Eliot, it was just over 15 million. At SWFT, it was slightly larger at 32.5 million. But needless to say, both teams have worked extremely hard to achieve a significant amount of work on the capital programme. It has been challenging. I think some of the decisions on capital funding through the year from the system have put extra pressure on, but all the teams have risen to the challenge. We've had a lot of flexibility in the programme towards the end. George Eliot supporting the system underspend, and the SWFT medical equipment team in particular doing a lot of work to bring forward some of our medical equipment capital purchases, which almost takes the pressure off next year's programme and allows us to push into some of our larger projects. So it's here for noting. I'm happy to take questions, and it's just a huge thank you to all the teams because it has been quite a year for capital development.
Phil.
Sophie, it's a great job and as you say, a great year. Sadly, I fear the next year might be more complex with geopolitical issues, as Umar touched on earlier on. Are you seeing supply chain issues yet from the events of Iran?
Not yet. Nationally, I know that Harkamar's linked in around the supply chain issues, like nationally NHS are looking at this. For us, though, it will be when some of our tenders come in the first quarter. So I won't know the impact until then, really, Phil, but we're not seeing it yet. But I agree. I think we will start to see this impact on our programme. I'm happy to bring that back as well, because you know, in terms of how that will impact it, maybe at the Q1 reporting.
Thanks, Sophie. That would be helpful. I noticed that there were two quite chunky projects in the SWFT capital programme last year, and I echo your thanks to staff for their determination and flexibility on making sure that we access and spend as much capital monies as we can. So it was the audiology and medical day case modules. Were they, I know we're only on day one of New Year, but did they hand over as hoped?
Yes. Audiology, definitely. Medical day case unit, yes. But still a little bit of commissioning work to do on that one. But yes, I believe we got them into the programme.
Thank you.
With a lot of hard work.
Yes,
So.
yes, without doubt.
Sorry, Sue, I was just going to say, what's great is I think sometimes we focus so much on delivering the projects, we forget the impact. I think particularly at SWFT now, we're so used to having these large capital programmes. But the impact and the benefit for patients now of that audiology service being off-site, easy to access in a modern facility. So I think we need to do a bit more around celebrating some of those. So I've asked the comms team to do more from a George Eliot and SWFT perspective to remind us why we did them, because I think we've got our heads down delivering them. We forget to do that celebration. So I'll make sure we pull that through to the public as well.
Great point. Thank you. And you still have the chair for the Green Plan twice yearly update.
Thank you. So this is a high-level update on delivery of the Green Plan at George Eliot and SWFT. We are in the position we expected at this point. We're working through the targets that we've set, and there's a number that have been achieved, partially achieved, and some that still need quite a bit of work. We have quite a good infrastructure to monitor and track this through the organisations, and more recently George Eliot are joining that infrastructure in terms of that strategy kind of coordination group and making sure we are on track. So some great work happening really, and we'll continue to progress on the Green Plan, and we'll highlight any barriers to any of the targets that we set at board as it continues to move forward. There's more work to do around that consistency, I think, at George Eliot and SWFT, but we've got Sean and Chris working together to help us achieve that. Happy to take questions.
Thank you, Sophie. This is, of course, an area where we aspire and do lead the NHS. Any questions and perspectives on the Green Plan from colleagues? I had a request, which was that it would be good to see, perhaps in future updates, a spotlight on one of the areas of the Green Plan, and I wanted to suggest that perhaps the first one we could do could be on the digital transformation, supporting the Green Plan. So because there's so much in this work, I appreciate the brevity of the paper, but I thought perhaps each time we could bring to life one of those work streams, perhaps one that's common to both trusts. So that was my request, and it was at this point that I wondered around the impacts from the war in Iran and conflicts more broadly on utility prices, for example. So you've mentioned already that you're happy to bring something back on that. I think perhaps looking at the green aspects of it as well would be really helpful.
Yeah, more than happy to do that. We do the spotlights in a workshop, but bringing them into the public board papers is a really good way for us to demonstrate that. And I'll work with Robin on the digital transformation piece as well, linked to this. The energy, it might be worth me bringing in an update back to board as well about where we are for both trusts on that, because we're locked into different contracts and what that looks like and maybe some of the risks around that. So I can do that as well. So
thank you, that would be really helpful. Great. Well, we're moving on to the quality part of our agenda. So moving to Fiona to talk about safe nursing, midwifery and allied health professional staffing, please.
Yeah, thank you. So this is the quarterly safe staffing paper that you're used to seeing, and it says a very similar picture really to previous papers, with very little change on a broad scale. I think it is the first of the combined papers from George Eliot and SWFT, and I'm hoping that's helpful from a comparison point of view. I think broadly it provides assurance on processes around safe staffing and the monitoring that we do. There are differences between George Eliot and SWFT, particularly with the temporary workforce model that we use, and we are doing a piece of work. One of the focus piece of work for this year is to compare the quality and cost effectiveness of those models, and we'll be bringing that through in terms of the internal governance. There is so good things in the report for both sides. You know, registered nurse staffing is in a much better position than even a year ago, but definitely you know, over the last 4 or 5 years, registered nurse staffing is in a totally different position. We used to run on sort of 20% vacancy, and we struggle to fill vacancies now with registered nurse staffing, which is a totally different problem then, that you're not able to guarantee even newly qualified nurses jobs now. So we're doing all we can with universities and with our budgets to ensure that we do commit to providing work for our local students as they register. Theatres, if you remember a few years ago, or even a few months ago, theatres was a real hotspot for us in terms of vacancy position and sickness, and that isn't the case now. All the work that we've done around retention recruitment into theatres has really paid off. That's specific to SWFT, and there is still a slight concern at George Eliot, so we're going to need to we are doing some work to mirror the incentives and pieces of work we did around theatres at George Eliot now. However, the main challenge, and one that we talked about in the workshop this morning, is an increase, and it looks like a slight increase in the paper, but I just wanted to bring it to light in CSW vacancies and sickness, and how that is affecting both a kind of a vicious circle in some areas, where if you have more people off sick and more vacancies, then you know that triggers more people going off sick, and you get into a cycle of managerial, particularly stress and anxiety, but also stress on the workers that are here. So we do need to urgently do a piece of work about clinical support workers, their rates of pay, making sure that they are aligned across the two organisations and with the national pay rates, and also with their recruitment or their retention. So that's the challenge for this paper. It's only a slight increase in this paper, but just to remind you that this only takes you to December, and January and February have seen that increase. So you'll see that in future papers. That's our area of stress at the moment. Happy to take questions.
Thank you, Fiona. Questions or perspectives, Fiona, on safe staffing? Fiona, I noticed one point which in your report, which was that you've seen a theme that some aggression from patients is rooted in longer stays because of delays in discharge. And there's mention of working with our partners on that. I wondered if you could tell us a bit more. Is that about discharge to assess, and which partners are involved?
No, it's a specific piece of work that we need to do with our mental health and learning disability colleagues and partners, Sue. So we have seen an increase in people with dementia, or sometimes undiagnosed dementia, but other times diagnosed, with mental health concerns and learning disabilities, all being admitted to our hospitals, sometimes with physical needs, physical health needs, but other times not. They're just in social crisis. And we need to work with our partners to better understand the offer to the public around crisis intervention, admission avoidance, but then when they do need admitting, how we keep their length of stay as short as possible. So when they're ready to go out, how we discharge them, and that's around care and provision in the community, from again our partners like CWPT or social care, providing complex placement for mental health, learning disability and dementia. So it's care home provision or social care provision I'm talking about, really.
Thank you. That's clear. I was on the wrong track, but perhaps that's something we could, when you think it's an appropriate point, invite those partners to come to workshop and discuss the way forward, because I know that obviously dementia care is a very important topic locally, and it would be good for the board to support progressing that work.
Yeah, okay, no, happy to.
Thank you. Have we got Lorraine, Sarah? You'll be better on. Yeah, brilliant.
Yes,
welcome.
I'm here.
Welcome, Lorraine. Sorry, I'm day one, but I'm getting there.
Welcome.
Thank you. Great to have you here to talk about perinatal quality and safety report.
Thank you, Chair. So take the report as read. Obviously, this is the first joint perinatal quality safety report for George Eliot and SWFT, so a little bit longer than my usual reports, but just to advise, a lot of the detail has been discussed at Quality Committee in Common. So this is just providing enough detail for you, but the in-depth conversations have been had. This is also Q3, so it's October to December 2025. So Q3 was busy for births in both George Eliot and SWFT. We welcomed a lot of new babies into the world, which was lovely. Our stillbirth and neonatal rates were low in Q3, and our rolling 12-month rates are still way below the national average, which is pleasing to see. We completed 100% on both sites for one-to-one care in labour and supernumerary status of the shift leader. We've had no coroner 28 regulations and no concerns raised from CQC. or MNSI. We have 2 open MNSI cases under review at SWFT. Our midwife to birth ratios are positive in a quarter. Our vacancy rates, as Fiona has discussed in maternity, are very low. And we have, where we have got vacancies, they've already been recruited to. And actually, we really struggled to be able to provide jobs for our newly qualified band 5 midwives. And there was a national funding to try and support those midwives that qualified and didn't have any jobs. So we have been able to recruit an additional with that funding. Our BAPM compliant, so it says you've got old and new. So obviously BAPM put out new compliance in December. So we were compliant for the quarter, but obviously we're just reviewing what that new compliance means. And we note that for neonatal medical staffing, we are going to have to provide additional resource. So there are business cases underway. So going forward, we will be not compliant until we've had those business cases going forward. But for the fact of CNST and MIS, for the quarter, we were compliant. Only one moderate incident in the quarter for George Eliot, which has been detailed and learning shared in the report there. I suppose our area of concern is our sickness. It's particularly driven by a long-term sickness. We're working very closely with HR to look at our sickness and reviewing every case to ensure that we can get our staff back to work and supported in that return. We had 5 complaints at SWFT and this was December's. There were no particular themes. Some of those, a couple were just related to our capacity. Obviously, we put a capacity acceptance criteria in for SWFT because of our ever-increasing capacity of births. And at that point, we hadn't got an appeals process, so some of those went to complaints, which we have now rectified with an appeals process. It means that complaints have gone down. There was just a little bit of negative feedback from a couple of our trainees from the deanery. That was 2024's data. Our medical staff are working very closely with our trainees and to look at that feedback, and we're just awaiting 2025's feedback. Really pleasing to see that our prompt training and MDT training is generally above what is required for a KPI. There were just some hotspots around safeguarding, but just to give reassurance, those staff have trained now since December. There have been a couple of national maternity reports released. So one is around the maternity care bundle. That's in relation to trying to reduce the mortality for mothers, and there's 5 areas, particularly things around VTE, epilepsy, perinatal mental health, whole bunch of recommendations that we need to work towards. So we're just starting our gap analysis for that also. And also in December, the maternity outcomes safety signal was released, and this is to try and provide trusts where there may be increased mortality within the interpartum care, early signals, and so we're working to review the SOPs and everything that we need for that. Those are the main highlights I wanted to pull out. I suppose just to say we've got a really good celebration. Our male midwife, Robin Malloy, received a Daisy Award in December, and really pleasing. He's the first male midwife in the UK to receive a Daisy Award, so we celebrated that really well. So happy to take any questions because it's a very long report.
Thank you, Lorraine. Yes, very wonderful celebration there. Questions or perspectives to Lorraine? Phil?
The point on smoking in pregnancy, I double-taked on when I was reading that the other day. And I just wonder if you think we're doing enough on prevention, and have you got all the support you have on prevention?
Obviously, we know smoking is one of the causes of stillbirth and neonatal death. It's part of our Saving Baby's Life care bundle. So obviously, SWFT are 100% on that. We have a dedicated smoking cessation team now and tobacco dependency, so vapes and things, we're going into community. I think there's always more to do that. I think we see peaks and troughs around smoking. We know it's including around deprivation, so we see higher rates in George Eliot because of the health inequalities there. So I think we do need to target a little bit more into the community there. So I think there's always more work we can do to reduce that, but there are national drivers that we have to adhere to. But I think it's always a focus to try and prevent those stillbirths from smoking.
Thanks, Lorraine. I had a question. One of the risks in the report speaks to the access to fetal medicine specialists, which I know has been a sort of medium to long-term issue. The way it's expressed in the report, I wasn't clear whether the plan is to recruit one to the trust or whether the plan is to continue to try to access through an SLA with tertiary provider.
Yeah, absolutely. So obviously our tertiary provider is UHCW. They have I think fetal medicine consultants are very rare. It's really difficult to recruit. So they do struggle to provide that service sometimes when there's sickness or annual leave. So we did a joint recruitment with George Eliot. So we have a consultant at George Eliot who is able to provide the lower level fetal medicine services in-house so that we're not transferring all of our care to HCW. We just need to replicate that, should I say, at SWFT. So we haven't got a dedicated fetal medicine consultant at SWFT. So that's an area that we want to focus on, but knowing that it's a really specialised area. So nationally, there's some work around with the deaneries and the Royal College of Obstetricians around how can we focus on that fetal medicine speciality. So otherwise we transfer our ladies to Birmingham, which is a bit far for them, but actually that's very specialised. So that we are really restricted with what services we can provide, but obviously we're looking at what we can support in-house because we're starting to see that work very well at George Eliot. So, but it is around training and funding for that as well.
Thank you for clarifying. Any other questions for Lorraine? David.
Yeah, the only one I know this is only for Q3, so but I was interested in the home births because we're still one of the trusts that still offers home births, and I've been made aware of quite a number of local, certainly within the Midlands anyway, trusts who are now declining offering a home birth facility. I'm just wondering how we're going to plan. Are we going to continue offering home births? And if so, how are we going to manage it? Because it's obviously, it takes more time to do. I mean, I'm not saying it isn't a good thing to do because it is for some mothers, isn't it? But I'm just concerned how we're going to manage the future because I can foresee, because we're doing it and others aren't, we're going to get more people wanting to take up our offer.
Yeah, thank you, David. There's been a lot of work, as you know, around home birth provision and women wanting care outside of what we class as guidance. So there's national work going on around that. There was a prevention of future deaths that came from a Manchester coroner. It did go to NHS England, but they asked all organisations to review whether they felt that they were providing a safe service for home birth. We've done that review. That paper went to Joint Management Board. It's going to be an ongoing piece of work because we have two different systems. So at George Eliot, we have midwives on call. So we have to look at that provision. And then at SWFT, we have our midwives that go out from Bluebell would go out to facilitate those home births. It's a lot of resource, and for our home birth rates, less than 1% on both sites. So the longevity of that is something that we're going to have to work through and resource. And we note that there are, as you say, local organisations that didn't feel that they could provide that safe service and have stopped their home birth service. But obviously that provides issues for women wanting choice, and we know that some women are taking Gloucester, for instance, to the High Courts around that provision. So where we can provide a safe service and provide choice, we will do so, but it has to be at safe. So we have to make sure that we risk assess and provide a safe service. So it will be an ongoing piece of work, whether that is sustainable. But there are, I say, there's a national working group looking at home births of, I think, 16 different areas of recommendations about how we can facilitate that going forward. So, yeah, it's a concern. It's an area where we have got some vulnerabilities around provision at home.
Thank you. Umar.
Thank you, Chair. Thank you, Lorraine. Just a quick question. Do we know, out of interest, what is the cost difference between what it costs to have a home birth and the cost of having birth within a hospital setting? I would just be intrigued to know, actually, what the difference would be. But clearly, from my perspective, it's the safety aspect that has to be absolutely top of the priority list. And obviously, I know that we've done learning from other trusts in our kind of areas in the Midlands. So yeah, that would just be interesting to know. If you don't know off the top of your head, that's absolutely fine. But I think it would be helpful to get an understanding of that for the future if we decide that we carry on with it or don't.
Yeah, absolutely. Obviously, we know that high risk births, as the zone sections, so very expensive. So we know that having a normal birth within a hospital setting is a lot cheaper than that. We do encourage, obviously, at SWFT, we've got our Bluebell Birth Centre, having the resource to send 2 midwives out to a home birth. Taking that resource away sometimes can impact on our acuity and our staffing. So actually, it's probably cheaper to have a low risk birth within the organisation, perhaps on Bluebell, than sending them out into community where we're taking that resource away. And obviously, because at SWFT, those midwives are coming from Bluebell, it would mean closing Bluebell to facilitate that. So we have to weigh up that acuity and risk as well. So to answer your broad question, it's probably low risk birth is cheaper than high risk birth, but home birth comes at probably at a higher cost as well because of that safety aspect.
Thanks, Lorraine. Thank you for your. Oh, sorry, we've got Sophie.
Sorry. So it's probably worth us having a deep dive on that, isn't it? In terms of like in planning or something, just to understand how we're managing it. It's a fair point around like looking at it. We talk about all the different lenses, the safety, the and the sustainability, I guess, as part of this as well. So it's probably a helpful exercise for us to maybe take away and do, just to support you, Lorraine, I guess, in that kind of decision as well.
Thank you.
Fiona.
Yeah, I agree, Sophie. We because we're doing a piece of work, aren't we, about the wider maternity and the capacity and demand model there. So home births being part of that would be really helpful, Sophie. The piece that I was going to just mention, Lorraine, is because this is a public board and public will be interested in this, is the home birth parameters in terms of the county line. So we've had some press interest and based on women's feedback to us that they want us to provide home birth services into other counties like Gloucestershire, Oxfordshire and on our borders. And I just wanted to make it really clear that traditionally, historically, counties have provided their own county home birth service for the reasons that you've said. It's very resource heavy. The further you go outside of the GP practices that we cater for and the boundaries that we manage traditionally in the community, the further you're extending that resource and that safety risk. So that hasn't changed recently. The only change is that our regional partners has closed their service, and so that request is coming to us, but we can't always fulfill that for safety reasons. I just wanted to make sure the public knew that they're always hard decisions, but they're always based on safety.
Yeah, thank you, Fiona. And we, every referral we get, we do review as an MDT and take that seriously. But we also then have to think of the travel for our staff to be travelling, if they're driving 40 or 50 minutes to a home birth, and actually if there was an emergency, the nearest unit that they transfer to and out of their scope of environment, etc. So it is about safety, absolutely. Thank you.
Thanks. We really are going to let you go now, Lorraine.
Thank you.
And see you again soon. Thank you.
Thank you.
Right, it's It's back around again, the annual staff survey, and as Adam has trailed, it's the headlines are very good news. Ashley, you're going to take us through it, I think.
I am. Thank you, Sue. Yes, so I won't go through all of the slides in detail. There is a lot of information there, and I appreciate colleagues will have already read through the report. But yes, kind of key overall headlines are very positive results. Having said that, I think one of the biggest indicators around staff engagement is actually the response rate. And you can see for both George Eliot and Swift, that response rate did drop compared to last year. Now that's in line with the national picture as well. And you can see we're broadly in line, just a little bit under the national average in terms of the response rates. But the staff survey, as always, is reported under 7 people promise elements, and those were included in the report. And then there's 2 overarching metrics also around staff engagement and morale, which are really helpful to see. And we've also included the response rate for Swift Bank staff. So George Eliot have NHSP as a provider, so we don't have their staff survey results there. So as I said, overall, really positive responses. And to caveat this with actually it's a continued picture from last year. Having said that, also there is a slight dip, not statistically significant, but in terms of the response rates. But overall, you'll see certainly in slides 6 and 7 for both Swift and for George Eliot, that for all domains, all people promise areas, we are certainly above the national average, and in many areas at the top in terms of the best performing organisations, which is really good to see. The detailed benchmarking is also included, so you can see where we sit amongst other organisations in the Midlands, and also information related to the foundation group as well, which pleased to say all of the trusts in the foundation group are reporting positively. There is an additional slide, and I don't think it yet has been included in the public board papers, but we'll make sure those are republished. It was only because they were received quite late from the Midlands Zoo, but we have got additional slide which I will make sure is circulated. And again, that just shows all of the trusts certainly in the Midlands and where they're performing. And again, both George Eliot and Swift are in the kind of top right quadrant, so really positive in terms of the results compared to our acute providers and sector providers. So that's positive to see. However, having said that, there are certainly areas where both organisations need to improve, and our aim and focus is always making sure that our staff have the most positive experience when they come to work, they have the resources they need, that they're cared for, and that it's an enjoyable, happy experience. So although we have positive results, we want to make sure we're continuing learning and listening to our staff. And having said that, because I'm talking, I'm conscious I'm talking around trust-wide results, there are nuances and differences depending on which staff group you work in, if you have protected characteristics, and those are really important for us to pay attention to. And there's information, again, within the slide pack, certainly around the experiences staff from ethnic diversity's experience, and also those with disabilities, which we'll kind of pay close attention to. There's information within the slides around areas we've done really well. So from a Swift perspective, really positive in terms of people recommending the place, Swift as a place to work, that they would be really happy for their friends and family to be cared for by the organisation, which is really significant. And also the free to speak up processes, so that staff feeling confident if they did raise a concern or they did speak up, they would be listened to and it would be acted upon, and that's great to see. Similarly, from a George Eliot perspective, so the positives there around staff understanding their responsibilities, feeling that there are shared objectives. The feeling of team comes across really well in George Eliot, and I think that's linked to certainly the culture there, with it being a smaller organisation, has a very strong community family feel, and that's come through quite strongly through the staff survey results. In terms of areas though of decline, and again where we need to pay attention to for both organisations, probably not surprisingly, is around the health and well-being. And we'll see that across, it's a national picture as well in terms of the declining picture, certainly from a sickness perspective. And we know both organisations have high sickness rates at the moment, and there's continued work to do there around not only reducing sickness but supporting our staff's health and well-being. but particularly for both organisations around musculoskeletal issues. And that's something we're working with around our occupational health and physiotherapy provision. But there's also areas around for George Eliot in terms of burnout, and for SWFT around that psychological support, which I know we discussed earlier in our board workshops. That will be an area of priority. Then in terms of SWFT, an area for us to relook at and improve on, and again there is work behind the scenes, is around the quality of the appraisal. So we know staff are having an appraisal, but what's coming through is that they're not necessarily feeling valued or able to fulfil their potential. And very similarly, from a George Eliot perspective, there is something around the positive, which is around the appraisals have supported people to do their job, but equally a decline is around, do they have the right resources to do their jobs? And that can be picked up in terms of the one-to-one conversations around what people need. So in terms of both organisations and our cross-trust focus areas where we've pulled out, and there is learning from both. So our speak up processes, so as we said, there have been some really positive feedback around SWFT processes, which we can learn from a George Eliot perspective. And then across the board, there is something around kind of workforce efficiency. So recruitment, retention, making sure that there's enough staff in both organisations to perform their role and they have the resources they need. Then another common area which is linked to the appraisals is around people feeling supported in their development and have access to opportunities. And of course, the last area of focus is around health and wellbeing support, so around that sickness absence support, MSK, psychological support, and also supporting our managers who have such a crucial but really difficult and challenging role in terms of supporting staff when they have so much on their plates and their capacity is being stretched. So the presentation does go into the detail. In terms of our next steps, what we are looking at is a different approach. So we don't just always go into that kind of continual action planning, because we already have strong action plans. Certainly from a trust-wide perspective, we started the divisional kind of priorities and focus and how we can move this forward collectively, but not being a tick box exercise. That's around having really meaningful conversations, and we're holding listening events with our staff so we can understand what more we can be doing in different areas. Our focus and priorities also need to be aligned to our organisational objectives. And this is about a continual conversation with our staff, and also relaying back in terms of where we've had their feedback, what have we done, that kind of you said we did picture, so that staff understand we are listening, we are responding, and we're working with them in terms of improving their experience at work. So in terms of overall, I think really positive results. There has been a slight decline in terms of both SWFT and George Eliot, not statistically significant, but a slight decline in terms of some of the areas compared to last year. But when we look at our sector providers, we perform really well from a staff experience, morale and engagement perspective. So I'll perhaps leave it there, Chair, and kind of happy to take comments and questions.
Thank you, Ashi. Glenn.
Always my favourite subject, this one. So thanks for taking us through that, Ashi. As you said, a really good set of results. And I think that decline mirrored the national decline. And across the group, they're really good as well. So, but as you say, there's always opportunities for improvement. One bit that surprised me a little bit, when you looked, so the Health Service Journal published the top 10, I think, nationally, and SWFT came fourth on the question. But actually, what was surprising was the response rate, because for a lot of the other organisations that were doing well on the survey, the response rates were much higher. So I wonder whether, as well as all the kind of specific actions, whether there's an action around how we improve the response rate for next year. George Eliot was slightly higher, but still quite low, really.
Yeah, absolutely, Glenn. And I think there's something there just around how much promotion, marketing, etc. we do on this, and understanding the time of year, which again is for all organisations. The staff survey is always asked over those kind of winter period when it's really challenging. But yeah, absolutely more we can do in terms of that increase in response rates.
Robert.
Yeah, sorry, I didn't want to jump on the response rate bandwagon, but I shall. It's just a really useful set of numbers on page 11 of 30, and it just might be worth giving Chesterfield Royal Hospital a call, given that theirs is 63%, to find out what they're doing. But notwithstanding the fact that our drop in the response rate mirrors the national one, do we know why there was even a drop? Because the concern here is that if people feel that nothing is going to be done in response to their input, then that could be one contributing factor.
Yeah, I mean, anecdotally, and again, when we do our walkabouts, I'm certainly not hearing that. The message I'm not hearing is, well, we tell you and you don't respond. So I don't know if other colleagues hear that, but that's certainly not coming through to me. I do think there was an issue around capacity and how stretched people were during that time, and obviously certain things will go on the back burner. But I think we can certainly look at that, certainly when we're planning for the next one, which will be here before we know it. And yeah, we can certainly reach out to Chesterfield, just to say as well, we have also been approached by the South East network in terms of, so I'm just going to go and talk about some of the work we do in terms of how we support staff from an engagement perspective, so we can share our learning as well with others.
Yeah, and just for the record, I wasn't trying to detract from all of the good stuff in it, because it's very positive.
Ramjit.
Well, thank you, Ashi. Yes, overall reasonable results, I think, given all the response rates. But I was going to go on to a previous thing. We talked about harassment and bullying and racial aggression from patients, but there's also, about 13 to 14% between in each organisation, harassment, bullying, and abuse from fellow colleagues. What is being done about that particular issue?
Yeah, I think that's a cultural issue, but also an issue when you triangulate that with what's reported formally, it doesn't always marry up. And certainly kind of, when people report things formally, it's a much lower rate. So obviously people are experiencing this and for whatever reason not reporting that. Now that could be because they feel like nothing's going to be done, that they won't be listened to. There's a variety of reasons. And so really kind of emphasising the support we get. And people can get through free to speak up. And again, I know we'll talk about that later in the agenda. And also our colleagues who work in EDI, where people might feel more trusted to go to. But I think also the staff networks have been absolutely amazing with us in terms of working with us and really challenging us on what are we doing to support our staff and for them to feel confident. So depending on people's different backgrounds and what the issues are, there is more we can be doing. I think our issue is staff are not reporting it, and so from a formal response, it's difficult to respond. But that is something culturally we do need to look at. Yeah.
Sophie.
We heard earlier about the vacancies in Fiona's paper, and we heard about it in workshop. So as well as tracking the areas where we need to make real improvements, it'd be good to track the areas that we've done well in and how we're using that. So how are we using some of the positive results that have come out to tackle some of the problems we've got, because we often are quite rightly focused then on improving those areas and forgetting actually there are some real positives in this report. So we need to use those as well to continue to tackle some of the problems we're seeing around vacancy, sickness, etc. So for me, when we look at this as a team, I think it'll be making sure we're maximising the benefits of this, what have come out of this report as well. And I agree on the response rate. This is a long survey to fill out. It's no surprise that corporate is really high. That ability to find some headspace on a computer when you're on a computer most of the days is much easier. So we probably need to think about the environment to allow people to do this, because you're not going to be able to do it in your day job if you're not based on a computer. So there's something more overt that we probably need to do about some of those groups of staff and how we actively support them to fill the survey in rather than just ask them. And maybe that's some of the focus, which we have done before, and it has led to increased responses. So we could look at doing some of that again.
Thank you, Sophie. Umar.
Thank you, Chair, and thank you, Ashi. Yeah, some positives within this staff survey. Disappointing, I will say, in terms of the take-up of filling it out. Just going on back onto Parmjit's point, it is extremely worrying that we've got that high percentage of bullying, harassment within colleagues. You know, from my perspective, this is about organizational culture. And, you know, if we have a zero tolerance approach to patients, you know, interacting with our staff, you know, we should have a zero tolerance approach to this. Sometimes it's not as easy. I do understand that, having been a HR director for many years. However, I think as an organization, that does really worry me, because when we've got an issue with recruitment and retention potentially, you know, you're going to have people potentially looking at going elsewhere because they may not be feeling comfortable within the organization. So what I would really like to see as a non-executive director is to actually see what real actions we're taking to deal with that, because it's completely and wholly unacceptable, regardless of whether it's racial, sexual, Islamophobic, religious, whatever that is. I think as an organisation, we're a good employer, and I think we need to stand up against such poor behaviour.
Thanks, Seymour. And certainly that's something we've discussed as executives. An opportunity for us working much more closely as to organisations is to reset our expectations and our standards and our behaviours and our values and what they mean. So that's certainly something we are taking forward.
Fiona.
Yeah, I really agree with you, Umar. I think having stepped into George Eliot, and I'm going to slightly contradict actually what you said, because I do think we hear staff in George Eliot say that they don't think staff on staff bullying or harassment has been taken seriously and has been listened to. And so we are much more proactively stating that and being more active in that space. So we talked earlier about having a weekly panel that discusses all staff assaults incidents, which has just been put in the diary, and you know, that is a way of actively saying, okay, how are we going to deal with this one, and getting some consistency and some timely action. We've also put in the freedom to speak up, but also the in-phase anonymous reporting system, and we do need to do a bit more time work on getting that out and well known within staff groups, but that is now available to them, because that was putting them off, I think, in terms of them having to put their name to the issue. And we've just implemented a new policy at George Eliot, which is the position of trust policy, which hasn't historically been in place at George Eliot. So but I would value any other thoughts and views on that. I don't think staff have felt that we've been active enough in that organisation, particularly on that.
Fiona, thank you for clarifying some of those changes that are going in. I couldn't agree more that momentum is really important when these cases are brought to our attention. And I also wonder, a thought that came to me looking at the staff survey was looking at which organisations have managed to drastically reduce abuse and harassment from patients, and how they've done that, because that will be very visible to staff. And I'm happy to talk to Ashi or whomever offline. I speaking to somebody from a mental health trust in the east of England who had a real grip on this and had managed to completely transform the staff experience on wards, and had changed the way that they handled abuse from patients and families. So very happy to join you up with that person. But you know, there will be some best practice out there. So it would be great to be able to identify that through the staff survey results. Umar, your hand is still up. Did you want to come back in?
So, and sorry, just very quickly come back. Apologies. Fiona, I completely agree with you. I think that I personally, it's something I think that we need to take a real stand on, because it will show both to the communities and to our staff that we value them. You know, from my perspective, this is not something new. This has been around for a long time. You could go back 10 years and look at staff surveys when I was in the NHS, and you will still see the same things. The worrying thing is now it's almost at triple the level, not maybe one or two double, it's at triple or even quadruple. So from my perspective, it's a reflection of what is happening across society. But I think from my perspective, we are an employer, and if our staff are not behaving in the appropriate manner, we need to make sure that we take a clear line on that, even if that might be an uncomfortable. So we need to get comfortable being uncomfortable, to use that term.
Thank you, Umar. Thank you, Ashi. Thank you, everyone, for your contributions. And obviously, we look very carefully at these issues regularly, so they'll remain under close scrutiny. Let's move on to the patient experience report. Fiona.
Yeah, thank you, Chair. So again, this is our quarterly patient experience report that you see regularly. It summarises the main quantitative feedback that we get from patients in respect to the friends and family, formal complaints, PALS, feedback and national surveys. As you can see, it's laid out as a comparative table between George Eliot and SWFT, just to try and start seeing the differences, seeing where the best practice is and sharing that at pace, and challenging both organisations to continue to improve based on sharing that best practice. Just as to note, the patient experience team across George Eliot and SWFT are currently joining as one team to do exactly that, to share resources and share experience. There are some stark differences, and you'll note in the report. Broadly, patient experience reporting through these KPIs is positive from both organisations, but there are some differences, particularly in response rates. There's a much higher scores at SWFT, for instance, in terms of friends and family feedback. However, the response rates are lower. So the number of people giving feedback at George Eliot is higher, with their positivity being lower. The number of complaints at SWFT is higher, but the PALS concerns are much lower. So the team, as they structure across the two organisations, one of their priorities is to make sure that we're counting apples and apples, pears and pears, complaints and PALS the same, because one of the observations is that things are classified differently. There's woolly national guidance on this, so each organisation has taken it slightly differently. So we just need to align that and make sure that we are using the same definitions. The good news, as I said, is most of our patients do report on a qualitative basis from a positive experience. So we know that triangulates broadly from our observations as we triangulate when we do our board to ward or speak to patients, speak to public. Broadly, the public at SWFT and in Nuneaton and the north of Warwickshire are very supportive of their hospital and community services, and get very good care from individual members of staff. But we don't always get it right, and you'll see in the report that the number of complaints and the improvement work that we've put in when we've had that feedback. The challenges that have come recently from some of our surveys have been around the patient experience in waiting, either in a waiting room, in A&Es, or on waiting lists. And so we do need to be being, looking at that and being proactive in our response to that, and that's some of the priorities for this year. Staff attitude when under pressure, and that, you know, that's not unexpected, but we need to support staff to maintain that emotional resilience and compassion even when they are under pressure, despite what we've talked about several times today about the staff being sometimes subject to really difficult behaviour and challenging behaviour from patients and visitors. Their job is to remain compassionate, so we need to help them to do that. And last point really is just taking opportunity, because the numbers are there, how fantastic our volunteers are, including our governors, including our patient forum in that, how much they save in terms of hours of NHS staff work. But also the massive contribution that they have on patient experience. So a big thank you to them. Happy to take questions.
Questions, perspectives for Fiona. Ollie.
Yeah, sorry, I'm a broken record on this point, but it would be very good to see some of the feedback we receive through social media in this report. I think any way a patient or those connected to patients want to give feedback to the trust, whatever channel it is, that's their channel of choice. And I think, and this is anecdotal, this is a suspicion of mine, I suppose, but I think for some people, the social media is an easier way to feedback to the trust than to go through PALs, and some demographics are more likely to feedback in such a manner. So it would be nice to see it. Okay.
I'm sorry I haven't picked that up before. You say it's a broken record, but I don't remember you saying it to me, so I will pick it up. Thank you, Ollie.
Thanks, Fiona. Oliver.
Thank you. No, thanks for the report, Fiona. And just, I'm probably not going to phrase this very well, but there's kind of been a number of recurring themes over the day today, haven't there? About, you know, you talk about, we talked a lot about violence, talk about the challenges on staff, the sickness rates, vacancy rates, the what do you call it, staff survey, and all of those things. And I'm not entirely sure what I'm going to ask, but it's about, is there a kind of common thread between those that we need to, rather than look at them individually, try and take a bit of a step back and say, are there different ways we need to think about the way we're approaching them that are going to have an impact across all of those? Because it feels a little bit like whack-a-mole sometimes, doesn't it? That there's something over here and we deal with that, but actually it has a consequential impact over there or something. Do you see what I'm trying to ask?
I really do, and I think my comment earlier in terms of productivity, I think, was possibly a bit of a knee jerk, and Harkmal was much more eloquent in her summary straight from after me in terms of we need to look at the data, we need to look at, you know, the actual facts. But I guess that's where it was coming from, that, you know, our services, the other theme that comes through all of our reports is how busy we are, and I think that does create stress to patients and visitors and staff, doesn't it? And how the pace of society actually has increased. So I don't know the answer either, Oliver, but I think there's something in that life is very busy, and we are expecting, our expectations as the public and members of staff is that we have instant, you know, services. Exactly. We can't have delay. We need to hear from our manager immediately. You know, there's something there in society that is driving a lack of resilience or a lack of compassion sometimes. Yes, it's a worry, but I don't know the answer.
Yeah, no, thank you. No, absolutely, that's exactly what I was asking. And you're right, it's kind of like we're expecting, the pressures are getting higher and higher, and we're asking more and more, sort of thing. And at some point, those don't align, do they? So how do we kind of try and step back and think about is there a different way of thinking about that? But you're right. I wish I knew the answer as well. But
Yeah.
thank you.
Umar.
Thank you, Chair, and thank you, Fiona. Recollecting from a previous life where I was responsible for patient experience in one of my portfolios, can you just enlighten me on incivility and what kind of complaints we're getting around incivility and that type of complaint? Because I found, when I was in the NHS, that was quite a big area where actually things could get resolved quite quickly without them getting to a complaint at a local level. So I'd just be interested to know that, actually. And then just kind of linking that to the HR bit, Ashley, which is around just looking at those particular departments where there are maybe incivility claims or complaints or murmurings, and seeing whether there's any behavioural issues, because I think it's a great opportunity to kind of cross map across and actually kill two birds with one stone, to use that term, because a lot of the time you'll find where we're finding the issues, what we've discussed earlier, we may get a duplication through our corporate complaints or PALS issues. So I may not have worded that correctly, but hopefully that makes sense.
Yeah, it's not described in the report as incivility, but it is described as attitude, and I guess I haven't broken it down. One of the actions in the report is that George Eliot need to move to complaints being logged in phase, because in phase does allow us then to triangulate themes a little bit more, and that will mirror also the data set that we've got at SWFT. I think incivility or lack of compassion, or lack of listening to the public is, as you say, often a theme that comes through. What our complaints and patient experience team have said at the moment is they're seeing that link to being busy. So it's some of the busiest departments that maybe can't close their door, or can't stop the flow of patients coming through. That's not just A&E, but sometimes maternity, sometimes palliative care. Those services that have to take patients, and because of the urgency of the concerns. I don't think it's widespread, and I think if you're asking my professional opinion with kind of anecdotal evidence, there's a lot of it is related to leadership capability, and we have done a lot of work but need to continue the work on our leaders, because if they remain resilient and compassionate to the staff, then that role models really good behaviour. So I think that's an area of focus, but you're right to highlight it. It is a theme.
Thank you, Fiona. It takes us into, we've got a report on freedom to speak up coming, which you've eloquently covered some of that. Adam, briefly.
Yes, I think Fiona took most of my point, but firstly, thank you, Fiona. It's really useful to see this report with the two trusts side by side, and it's helpful to draw out those areas where we can work together to do something differently. I was really interested by your point, Oliver, and I think that triangulation is something we probably need to do a bit more of. But as Fiona said, I think demand pressures play a big part in this. I think where we see challenges, they're linked to the busyness of the services and the impact on staff and patients, particularly for communication. And I think that links into our wider development programme, as Fiona says, with our leaders, but with wider workforce. I also think there's that link with the EDI issues. You said it well earlier, but we're seeing challenges in society which are now reflecting in the trusts, and we need to think about our response to that a bit more, I think.
Yeah, and I'm conscious of time. Do you need to come back?
I'm really sorry, Sue, but there's something So it's probably for Ravi and the information team. We have been talking about a kind of integrated dashboard where we could do this triangulation, and whether we could put complaints, freedom to speak up with capacity and demand and how many patients they're seeing, and sickness and vacancies in one area that can be triangulated easily. I think maybe that's the next step on our kind of data set and information set would be really helpful to answer that question. Sorry, thank you. That's all.
Thanks, Fiona. I think that it's important that action's picked up. So either we put it here or we put it elsewhere. But I know it's something that you've been signalling for a while. So let's do best endeavours on it. Okay, so we're on to performance. Integrated performance report with Adam.
Thank you. I'll do a very brief summary and hand over to my colleagues. So the report relates to February, and February obviously saw the tail end of the winter pressures that we've seen. So demand remained extremely high and acuity remained extremely high in both trusts. I think at George Eliot, we saw a continuation of the journey we've been on to improve our urgent care performance. That's reflected in the report. A little bit more challenging at SWFT, particularly in terms of the acuity, so a slight drop in performance in our urgent care services. Despite those pressures, I think it's really reassuring that our quality indicators remain stable, and we've had some great work in both trusts. My area of most significant concern in terms of the indicators, which we've already touched on in some of our conversations, is sickness. We had a good board workshop session on that this morning, and there is more work we need to do. Certainly there is a national trend to increasing sickness, but I think we can influence that locally here with some of the good work we need to do over the next few months. It's also been a really challenging year financially for both trusts. We are on track to deliver our plans for the year, but that's not without a huge amount of work by our staff across the trusts, and I know Ravi will talk more about that. So I'll leave it there, Sue, and hand over to my colleagues, and I think Fiona and Naj are first.
Thanks. If I kick off then with the mortality data, please. So the report contains, as I say, the mortality data for both organisations, in particular SHIMI. So that looks at in-hospital deaths and deaths within 30 days of discharge. And the headline basically is that both organisations are within expected range. For George Eliot, though, there has been if you look at the table in the information, in the paper, it has been gradually going up. So we are looking into this and doing a bit of a more deep dive and seeing what's leading to that. The early thoughts, it's to do with the coding and getting the primary diagnosis and the comorbidities properly documented, which can obviously affect that data. In terms of outliers within the SHIMI, so overall within expected range, but we have had an outlier notice for fracture neck FEMA, not only through SHIMI, but also from the National Hip Fracture Database, which very concerning. I mean, getting one outlier notice is obviously alarming, but to get two, and we really need to be focusing on it. These both occurred last year, so we set up an improvement group who've been working regularly, chaired by my deputy CMO over at George Eliot, and really focusing on the whole pathway for fracture neck FEMA, from the point of entry into the acute trust to the whole stay within the organisation, and looking at those key areas such as time from ED to getting to a bed, time to getting to theatre, getting orthogeriatric input, time mobilising after the operation, because they are really important. It's quite a time critical pathway, and that's where they've been looking at and making some improvements. So it's been an MDT approach, all the various specialties and stakeholders involved, doing deep dives when there have been deaths. And we're starting to see some improvement now. So for the latest period, whilst we still are outside the expected range for SHIMI, the outlier notice that we had from for National Hip Fracture Database, we are now within expected range. So that's improved. That's an early indicator, I think, that we are doing the right sort of work. with this particular condition. For SWFT, theirs is for SWFT, our shimmy is 0.99, which is really good and has been stable for a long time, as again you can see from the graphs. No outlier alert from shimmy, but SWFT have also received an outlier alert from the National Hip Fracture Database regarding neck of femur mortality. So we've set up a similar improvement group. This only came towards the end of last year. So we set up a similar improvement group and learning from George Eliot. So, some of the themes are very consistent with what we found at George Eliot as well. So the teams are learning from each other. And again, looking at the pathway from the beginning to through those critical areas that I mentioned. So as I say, that's where we are. No other outlier alerts though from shimmy for either organisation. The report also includes some medical examiner performance. This is a really important part, I think, of the process as well. We both employ medical examiners who are senior doctors, either consultants or GPs, and they provide independent scrutiny of every single acute and community death within our patch. So in other words, they become the eyes and local ears of the coroner. They oversee the whole process of the issuing of the death certificate, which is obviously an important process. And if in their reviews they feel that further investigation is required, then they can order that through either a structured judgment review or actually referring it to the coroner for further sort of investigation by the coroner's office. So the pack, again, the information there is around some of the performance metrics. So of course, once a patient sadly dies in our organisation, we do want to issue these certificates quickly as possible, obviously, and support the family. And that's another one of the functions of the medical examiner office, is to make sure that the death certificates are issued in a timely manner and to provide that communication, as I say, with the family for any questions that they have. There's a lot of learning that comes from all of these mortality reviews, and as I say, not only from the medical examiner, but from the morbidity and mortality meetings, and that's shared through the various governance meetings and mortality groups across both organisations. And then in line with us starting to sort of unify some of the meetings, in April, we'll be having our first joint George Eliot and SWFT mortality meeting. I think when I sit at the individual meetings, there's some really common themes that come out from some of these reviews that we do, often around things like coding, often around things like documentation, having escalation, proper escalation processes in place, those respect conversations where we, do not attempt resuscitation, those sort of themes come out. So we can sort of learn together with that and also see, why is there this difference in shimmy between George Eliot and SWFT? I know we're both within expected range, but SWFT have consistently been sort of in a really good position. So there's some learning from said both organisations there as well. Thank you. I'll pass over to Fiona now.
Thank you, Nad. So I haven't got anything specific to draw, or very much to draw out of my report. Most things are within normal range without any, huge improvement or significant deterioration this month. The only one that you will probably have noted is that the IPC targets or thresholds that we set for the year in terms of E. coli on C. diff for both organisations are off track. That is in line with national trends as well. Nationally, we've seen a lot more a bigger increase in C. diff and E. coli. To remind you, E. coli is a bacteria that lives in your gut normally, and therefore infections are often spread either by urinary tract infections and catheterization or through bowel surgery. So both of those in both organisations are under a significant scrutiny, and I can give assurance that our catheter care and urinary tract work that we've done and to prevent urinary tract infections in both organisations has been good, and I'm assured that we are compliant with all national standards on that. And so we are looking at the biliary conditions and the gastro conditions, and seeing whether there's anything in terms of safe surgery or stenting or diagnostics that we do in that group of patients that could prevent it. But everything that I've seen so far looks like the majority of these are unpreventable or community acquired, and so not associated with any deficit in our care. C. diff is usually caused either from antimicrobial usage being non-compliant with best practice, or environmental issues. Again, I'm confident our environmental work is good, and we do environmental audits on all of the inpatient areas, and we haven't seen any slippage in those standards. In terms of antimicrobial usage, at SWFT, we're very good at that. We have antimicrobial stewardship and ward rounds. There is a gap at George Eliot in terms of microbiology provision, and Naj and I are talking about how we fill that gap. Saying that, I can't see a direct relationship with microbiology support at George Eliot in these cases, but it is best practice to have that in place. So we're not nationally an outlier, but obviously we were set very high, tight targets on this historically in both organisations, but I'm confident that we're doing all we can to prevent those. I'm happy to take any questions. That's all I wanted to pull out.
Any questions for Naj and Fiona? Robert.
Question for you, Naj. Just a quick question about what you were saying about the checking on the clinical coding and data quality with that jump in the shimmy. I couldn't tell from the narrative whether you've come to the end of the review to see what the causation was, or whether that's something that's happening, and if it's the latter, when are you concluding on that?
It's ongoing, Robert, so we are still looking into it. The issue we have with shimmy, it's very difficult. Shimmy as itself gives us this figure. It's very difficult to actually interrogate it. What we're missing is another form of mortality metrics, and previously we had at George Eliot, we had HSMR from Telstra, and at SWFT we had HCKM, some other form. Both those contracts have expired. We are in the process of procuring HEAD. HEAD is the other one, which is healthcare evaluation data. It's another mortality metric, which is already being used by Wye Valley and Worcester. So the whole group has to say that we can then start to interrogate more, much deeper around conditions and see the impact that coding is having. What are we missing out in terms of, are we giving them the accurate data for them to give us an accurate sort of mortality metric back? So we are still trying to do the work with what information we've got with shimmy, but I think it will become easier once we start with HEAD, because I think then not only we can actually analyse the data much better, but we can actually look across the whole group and learn across the whole group from a very sort of like-for-like approach to the methodology and the numbers that we're looking at.
Okay, yep, thank you.
Right, let's move on to Harkamel.
Thank you. So in February, our operational pressures remained high across both trusts, but I'm really proud that there were some real notable areas of improvement. So at George Eliot, the 4-hour A&E performance improved to 80.2%, and that's the first time that the George Eliot has managed to get above 80% since October 2021. In addition, the 12-hour wait reduced, the ambulance handover delays reduced, but bed occupancy did remain extremely high, and capacity remained our key constraint. At SWFT, A&E attendances were lower than January, but that was due to the shorter month. The average daily attendances were higher, so indicating that February remained busy for SWFT. There was also a significant increase in the acuity of patients, so that's how we measure how poorly our patients are. So there was a 69% increase in acuity patients compared with the same month last year. Positively, A&E performance improved. It was below plan, but it did improve compared to January. 12-hour wait improved slightly, and bed occupancy was under 100% at 97.2%. And for both organisations, the focus on flow, especially utilising all our same-day emergency care pathways, continued into March, and both organisations were set up very well for the March sprint. From an elective perspective, RTT improved at both SWFT and George Eliot, and the number of patients waiting at 52 weeks reduced at both. In diagnostics, George Eliot improved, albeit they didn't manage to meet the standard, but did improve to 88.8%, which is fab. And SWFT achieved 97%, which was above the standard. So really excellent news, I think, on our elective performance. And then on cancer performance, just to remind everyone that relates to the January performance, not February. At George Eliot, the 28-day performance did improve, but it did decline at SWFT. I've talked quite a lot, and the detail is in the report around some of the delays and the challenges around the 28 days. I won't go into too much detail. The 62-day at George Eliot was 62.2%, and there was an improvement at SWFT to 67.5%. And across both George Eliot and SWFT, the strategy and the focus is clear. We are doing a systematic tertiary process review. We're working on our lung and urology pathways and doing some detailed process mapping, and working with the West Midlands Cancer Alliance on the pathway reviews. And then I've noted some more detail in all of my focus slides, so I'm happy to take any questions.
Thank you, Harkamal. Questions, perspectives to Harkamal? Harkamal, just a quick one for me, which probably could have raised in the medium-term plan. It's not surprising, is it, that acuity is going up, given that people that are less unwell will increasingly be seen in the community rather than in the hospital? Do our planning assumptions, are they based on acuity remaining at this level as opposed to going back to previous levels?
So informally in our planning, we consider acuity. We had community services this time last year, so there is something more interesting, I think, going on that we're trying to figure out at the moment in terms of that real step change. That is statistically significant in terms of our acuity, and I think although we were feeling it, we wouldn't have necessarily guessed it. I think it's in line with our ageing population and many more of those complexities that we talk about at the same time, but it's not formally in our activity modelling because everyone can account for acuity slightly differently. That said, it is something that we are cognizant of, and you are right in that we have more admission avoidance, we have lots of really strong community pathways, we have same-day emergency care, so you would expect your length of stay to be higher, you would expect more poorly patients to be in hospital, so I think it's a fair challenge and something we'll take into planning as a check and challenge approach, I think.
Thanks, Harkamal. If there's no further questions, let's move on to Ashi.
Thank you, Sue. Yeah, so I will keep it fairly brief as well. So in terms of overall, from a workforce perspective, both organisations performing really well, particularly from a recruitment perspective and the time to hire KPIs. And similarly from a turnover, so both organisations within the expected turnover range. Appraisals and statutory and mandatory training, generally good, although there are some nuances. So from the SWFT perspective, the compliance is above target, which is great to see. There has been a decline there from a medical and dental perspective. Now we've picked that up within the organisation because I think there's also a reporting issue there in terms of where we're getting that data from and is that coming through in terms of the right reporting. But at the moment it does look like the medical and dental is below the target and it's obviously below this compared to this time last year. And then from a George Eliot perspective, mandatory training also above target, which is great to see. Has been a slight decrease though from this time last year, so that's something nice to pick up upon. And then similarly from an appraisal perspective, there has been a slight drop from appraisals for George Eliot. The biggest area, however, though, for both organisations is the sickness absence rate. So you can see, although there has been a slight improvement for SWFT, we need to ensure that is maintained and continues to reduce. And George Eliot has been a slight increase. Now, I won't go through all of the kind of interventions and approach and plan changes. We talked about that in quite a lot of detail at the earlier board workshop. That certainly is the area of focus for us moving forward in terms of supporting both organisations to reduce the sickness absence and to support staff health and wellbeing. And obviously linked to our earlier conversation also from the staff survey results where health and wellbeing is an area of focus. That's our kind of priority moving forward. But happy to pick up any other questions or comments.
Thank you, Ashi. We did indeed cover people in quite some detail. Umar.
Just a quick one, Ashi. How are we on retention of kind of critical roles within the organisation, specifically clinical roles where we're traditionally finding it difficult to recruit to?
Yeah, one of the areas, and I think we picked up on in early discussions also actually, is around our clinical support workers. And actually, I think there needs to be a huge drive around our CSWs. So that's one area that certainly we can focus on. And then there are other areas of hard to recruit roles, and we've seen that coming through where we're then offering recruitment and retention premiums, and some of them are obviously linked to the national picture. So podiatry, for example, sonographs, and recently reported in the news as well. So there are some areas, even in the States as well, where we've got those hard to recruit roles, but we tend to then focus on the retention of our staff as well as the recruitment element of it, and take that through from a divisional perspective, certainly in terms of the work we're doing. But yes, we pick up on those nuances as well.
Thanks, Ashi. Let's move on to Ravi with finances.
Thank you. This is the month 11 position. Year end officially finished yesterday, but at month 11 we reported for SWFT 0.7 million deficit against our 1.5 million surplus plan, so giving us a 2.2 million adverse to plan. George Eliot, we reported a year-to-date deficit of 7.1 million, which is consistent with its financial plan. The main drivers, as a number of colleagues have already mentioned, primarily are driven by the sustained operational pressures and increased demand that we've seen at both trusts, which essentially has resulted in additional capacity remaining open and higher expenditure on temporary staffing, linked in some respects to our sickness levels, higher sickness levels than we would like, and items such as increased drug spend. The pressures this year we've partially mitigated through non-recurrent sources, but this reliance does raise concerns as we enter a new financial year in terms of financial sustainability. In terms of efficiencies, we are slightly behind plan at SWFT, whilst George Eliot actually are slightly ahead of plan. But this does, for both trusts, raise concerns around relying on the one-off items rather than the sustainable cost reduction. Both trusts are forecasting delivery of capital plans, and as I said, given that we've just finished year end, most of our focus now is switching in terms of delivering the position, but also looking forward to 26-27, with the focus really on the run rate reduction and delivery of CIP to ensure we deliver our plans. Thank you, Chair.
Thank you, Ravi. Thank you, Ravi. Questions and perspectives on finance? Again, we covered that a lot this morning, and thanks to the team. Pass on the thanks to the board, to the team for everything that's underway around year end and the negotiations to make sure that all the hard work that's gone in to optimising performance is recognised in the year end result. So thanks very much. Right, we have one more item under performance, and this is for approval, and it's the key performance indicators for next year. Harkamel.
Thank you. So there's not much to say. The paper presents the annual review of the trust key performance indicators. It's also got the quality indicators in there for 26-27, and it's just to say that they've been refreshed using NHS England's planning guidance. And have been agreed with operational informatics and nursing colleagues, so that there's consistent monitoring, and all of our scorecards will be updated in line with this.
So welcome seeing the improvements and the the measures to produce better care outcomes for the public. Are there any questions or perspectives? Okay, we're here to approve this. So if anyone is not willing to approve, please raise digital hand. Not seeing any hands, so that's done. Thank you, Harkmal. Governance. Adam, summary of ratified policies.
Thank you, Chair. There were 6 ratified policies. I'll take the paper as read.
Thank you. Any questions, perspectives? Moving on to the annual review of board committee terms of reference. Sarah.
Thank you, Sue. So presented in front of you are the proposed amendments to the audit committee terms of reference, the appointments and RENCOM and Foundation Group Strategy Committee terms of reference. Each committee has considered the proposed amendments, put these forward for the board's ratification. Just to note that the terms of reference of the joint board and also the quality governance committees that meet as committees in common, those terms of reference have already been ratified by the board, so I haven't brought them back today. They'll be part of the annual review as a whole next year.
Thank you for that clarity.
Thank you.
Anybody not willing to approve these terms of reference at the moment, please raise your hand. No, all approved. Thank you very much for everyone on those committees and on your team, Sarah, for pulling those amendments together. We are still with you for the Register of Interests.
Thank you. So this is the annual review of the registers of directors and also the Register of Directors' Interests. So the changes are shown as bold and strike through or for any deletions, and then just bold for any additions. Apologies because there are quite a few amendments due to some changes, hence the longer report, but it's here for the board to formally approve. To formally note, receive and note. Thank you.
Thank you, Sarah. I noticed that Glenn's previous title as National Finance Research Director is still in there, but I think that finished yesterday. So I don't know, is Glenn still with us?
He's not, but I was informed to keep that on because some of the work is staying, so I'll need to check if that is incorrect. So
definitely some of the work is staying. We just need to make sure we give him his correct title. Thank you. Okay, on to the BAF. So Adam, you're going to cover both the George Eliot and, first of all, we're going to look at the quarterly reports and the update on the risk management strategy.
Yes, I will cover both of the BAFs together, Chair. So the SWFT and George Eliot year-end position BAFs are included in the papers in their full detail with the risk registers. So I don't propose to go through the detail, but I think important to note that on the whole, we've seen risks reduce through the year, as you would expect, as our objectives are delivered. And on the whole, we've delivered our objectives for the year. So just to provide the board with that assurance. In terms of our approach to risk management, I referenced this in matters arising earlier, but we have spent a fair bit of time reviewing and refreshing our approach. We had slightly different methodologies in the two trusts, including slightly different methods of rating our risks. For next year, we're bringing those into line, so we have a consistent method of risk rating to avoid the confusion. We will also present our BAFs and manage our BAFs in the same way. So there'll still be two separate BAFs for the two organisations, but they'll be managed in a consistent way. We are also bringing together our risk management governance, so we'll have a single risk management board for the two trusts, and the first meeting of that group is in a couple of months. And again, that will help with the consistency. I think what we also see, as you'll see actually on the shared risk logs, is very similar risks across the two trusts, albeit with local flavour to them for the specific site-specific issues. So a single risk management board will allow us to ensure we're managing these in a consistent way. I will leave it there in terms of the BAFs and the update, but I'm happy to take any questions.
Thank you, Adam. That sounds very sensible in terms of the timetable and bringing those together. Questions and perspectives on the BAF for Adam? BAFs? No, thank you. I think we're all assured at the risk management approaches. Okay, so next we are on Register of Sealing Annual Report. Sarah.
Thank you. So I think this is self-explanatory. It's just here for the board to receive and note.
Okay, thank you. I don't imagine there's any comments, so I'll move straight on to the Joint Policy Review Group and Joint Management Terms of Reference, which we are here to approve, Adam.
Yes, these are the annual updates. So there's no change, no significant change to the Joint Policy Review Group terms of reference. It's just its annual review. The Joint Management Board, this is the first time board will have received this. We brought our management boards together, as you know, over the last few months into a single joint management board. We took advice from the Good Governance Institute on our terms of reference and refreshed them on that basis. So those terms of reference are here for approval.
Thank you. Any comments or perspectives on these items? Huge amount of work going on behind the scenes, bringing this joint leadership governance together. Really appreciate, although we're moving through them at pace, that's because they've been done very carefully. So thank you. Anybody unwilling to sign these off, please raise a digital hand. No, great, that's done. And I think we are welcoming Deepa to give us the Freedom to Speak Up Guardian report. Welcome, Deepa.
Thank you. Thanks, Sue. I'll take the report as read. The key change since we last reported in this period has been a transition from Datix to InPhase in terms of our case repository and reporting functions. So a lot of work's gone into working with the build consultants to create and implement the Freedom to Speak Up app. There's some elements of the form and reporting functions that still need some work and amendment, but it's in place and being used. As I say, we have started to receive cases through that additional route as well. So it seems to be getting out there, but we'd very much appreciate the board's support as well in disseminating those messages about this additional route for staff to speak up, which also allows anonymous reporting as well. The team has also spent a significant proportion of time and resources in this period conducting listening sessions and supporting works to better understand workplace culture in specific areas, namely maternity services at SWFT and ophthalmology at George Eliot. And the key themes from those areas are detailed in the report. As behaviours, incivility, team dynamics and relationships with managers and culture continue to be raised as concerns which significantly impact our staff. This can be through their reduction in confidence, ability to challenge, willingness to support others and health and well-being. As a consequence of that, we're looking to do a piece of work to evaluate the impact of civility training where teams have had that as a bespoke session in their teams over the last couple of years, so we can try and better understand the impact of that training and any levels of improvement as a result. And in terms of next steps, it's time again for the self-reflection and planning exercise to be completed by the board and senior leaders. So this month surveys will be going out to all of you for completion. So please keep a lookout for those. Happy to take any questions.
Thank you, Deepa. We're really indebted to all staff who speak up and keep us appraised of of concerns. Any questions or perspectives to Deepa? We have actually, Deepa, we've been covering quite a lot of staff concerns earlier in the day, so let's see if we've got anything outstanding. Sophie.
A quick one. I'm just wondering, should we be concerned that the Speak Up, Listen Up, Follow Up training numbers at SWFT are like significantly lower than the ones at George Eliot?
So at George Eliot, a couple of years ago, all of those modules were in inverted commas mandated, so it was tracked to compliance, and therefore that encouraged all of those staff to get on completely, and that wasn't done at SWFT, so that would explain that difference.
Okay. I guess is our plan to get that up at SWFT, or are we?
Ideally, yes. I mean, I think traditionally the view has always been that there is a really good speak up and reporting culture at SWFT, which, you know, absolutely there is, but there's always room for improvement. And I think particularly with the responding and feedback and closing that loop, so for managers to understand the listen up and follow up side of things is really important.
Brilliant. Thank you.
Fiona.
I'm just interested deeper in if those training sessions were mandated at George Eliot, did you see an impact in terms of reporting and managing Speak Up as a result of that training, in terms of, you know, making sure that it is actually effective?
So the change was definitely seen through numbers of cases coming through and increased awareness about the Freedom to Speak Up service. That was a definite noticeable change. Management understanding of responding and closing the loop improved, but there's definitely room for improvement at both organisations on that front.
Okay, thank you.
Adam.
Similar question, really. We heard deeper in the staff survey results that Ashley gave earlier that there is a theme around confidence in speaking up at George Eliot, and I don't think that relates to your team, but I think it relates to the organisation more generally. I'm interested in your perspective on that and any actions you think we need to take as a board to help address that.
I think what we hear a lot of is there is quite a lot of fear around speaking up, whether that's hierarchy or people have seen other people's experience of speaking up that hasn't gone so well, and that has discouraged people, or there continues to be a sense of futility whereby they don't have confidence in that there will be change, or if it relates to their managers, they're worried about the impact on them that they may feel as well. So all of those issues, I think, are relevant when it comes to confidence levels in speaking up.
Thanks, Deepa. Just quickly from me, thank you for providing extra detail around maternity to the board during the month. One of the actions I saw there was recruiting more Speak Up champions within that area, and it made me wonder, what is the coverage like of Speak Up support within services across George Eliot and SWFT? Are you comfortable that there's a strong network in place?
There are networks in place. I think they could certainly be stronger, and there is definitely, I think, a need for more promotion of that role. I believe there are discussions taking place around what that role actually looks like. So at present, it's Speak Up, Wellbeing and Inclusion in terms of the ambassadors that we support. But there are also wellbeing champions. That is a new role that's been introduced. So I think there is a need for some clarity around what those roles look like, what's expected of them, and certainly more promotion in all areas. I mean, the ideal would be that we would have at least one ambassador per department.
Thank you, Deepa. I'm sure support that sounds very sensible to be doing that review. Thank you.
Thank you.
Sarah, over to you for the Code of Governance compliance review.
Thank you. So this is a requirement for the boards to do this as an annual review. They have both been through the individual audit committees, and we're proposing that George Eliot declares full compliance with all of the provisions of the code, and SWFT declare non-compliance with provision 2.7 in section B of the code, which actually relates to non-executive director independence. And because we have a non-executive director from a medical school, we declare that as non-compliance, but it's got a justifiable reason, and then to declare compliance with the remaining provisions of the code. So it's here for the board's approval, please.
Thank you. Anybody got a question or unwilling to support approving this? Please raise digital hand. No, all good, Sarah. Thank you very much for that comprehensive review.
Thank you.
And it's you again, isn't it, for standing orders?
It is. Now, the full document is on admin control for board members to review, and the front sheet captures the key points of changes to the standing orders here for the board's approval, which then goes forward to the Council of Governors to ratify as the standing orders are part of the Trust Constitution. The SWFT Audit Committee did review the document in full, so they have had sight of all of the proposed amendments and were in support. So here for the board's approval, please.
Thank you. Thank you to the Audit Committee for reviewing and putting this forward with Sarah. If anyone is unhappy to approve the standing orders, please raise a digital hand. All good. Thank you. And we're on to items for noting and information, which is a substantial number of subcommittee updates. Let's rattle through them. David, we've got the Quality Committee in common held on the 18th of February and 19th of March. Thank you for the reports, which were very clear. Is there anything you need to add?
I don't think so, other than to make sure the board has noted that maternity received a MOS level 1 alert in February. And I can assure the board that all the necessary actions and learnings are actually in place and are being monitored by the committee on a monthly basis.
Thank you, David. Any questions to David? Okay, moving on to Robert with Audit Committee, the 11th of March.
Thank you. Yeah, thank you, Sue. Don't be fooled by the brevity of this report. It was an extremely busy meeting. We took a couple internal audit reports, discussed getting ready for the next audit with the external auditor, reviewed our own effectiveness, looked at the internal audit plan for next year, and the list goes on. So it's all there for highlights. Happy to take any questions.
Any questions for Robert? Thank you. We don't have Paul here today. He's given apologies. Are there any questions around the Audit Committee report for George Eliot? Ravi?
Did you want me just to do that? I think Paul asked me to just give
a
that's wonderful.
Thank you.
I'll take the report as read, but pretty similar to in terms of what Robert's just described, very busy meeting. I suppose the only other additional element to add for the George Eliot one is around the waiting list management issue and the audit coming back and just the committee asking for assurance on how we would be addressing the issues and timescales for resolution.
Thank you, Ravi. It's very helpful that the Audit Committee is looking at that in short order. Any questions to Ravi? No, thank you very much. Adam, the improvement board meetings.
I'm happy to take as read. I think the notes are self-explanatory.
Yeah, I found it very helpful to see these, Adam. Thank you. Moving on then, David, Council of Governors, anything to add?
Nothing to add from me, no.
Any comments from anyone? No. Foundation Group Strategy Committee, Glenn?
I think Glenn's not here, but I'm happy to take any questions and take these as read.
Fine, thank you very much for that. And then we have a number of minutes for the committee just presented for noting. So I don't think we need to go through those. They're all noted unless anyone has anything they want to raise. Great, thank you very much. I haven't been notified of any other business, but any other business on anybody's mind? Great, well, we have some governors and members of the public with us today. We haven't received any questions in advance. Is there anything that anybody would like to raise? Oh, thank you very much. Thank you very much to all the teams for the exceptional amount of work in this large set of papers today. And we will take a, we are running over. Let's meet at in 6 minutes for confidential at 5:02. Thank you very much.